So our first topic is lifestyle modification in adolescent PCOS. Dr. Payal Bhargava ma'am is going to speak on this topic. Ma'am has done fellowship in infertility, and ma'am is member of managing committee of PCOS Society of India, co-founder and director on board XPS Analytics Private Limited, consultant Sri Krishna Diagnostic Center, also consultant Pranada Hospital and co-founder of Divine Magic Foundation, a public health and awareness initiative working at grassroots level and digitally through its YouTube channel. So with this, I'm requesting ma'am for her talk on lifestyle modifications in adolescent PCOS patients. Over to you, ma'am. Thank you very much.
Thank you, Dr. Prachi, for your kind introduction. So my today's topic is lifestyle modifications in adolescent PCOS. It will be including how do we define adolescence, what is PCOS, why is adolescence an important time in PCOS, diagnosing PCOS in adolescence, how and why is it different, how do these young women present to you, how do we diagnose, and what are the lifestyle modifications. Adolescence is a period of human growth and development that occurs after childhood and before adulthood, includes those persons between 10 and 19 years of age according to WHO 2015 criteria. Early adolescence is defined as age group between 10 to 14 years and late adolescence as age group between 15 to 19 years. India has the largest adolescent population in the world, 253 million, and every fifth person is between 10 to 19 years. About adolescence. Major physical, psychological, and behavioral changes take place: sexual maturity and onset of sexual activity, development of adult mental process and adult identity, healthy responsible parenthood, great human resource for the society, growth spurt and physical activity occur, and menstruation occurs. PCOS is a complex endocrine disorder affecting women of childbearing age characterized by increasing androgen production and ovulatory dysfunction. It is a leading cause of annual ovulatory infertility and hirsutism. Women with PCOS have an increased risk of miscarriage, insulin resistance, hyperlipidemia, type 2 diabetes, cardiovascular disease, and endometrial cancer. The incidence of PCOS in India is very high. It occurs in 1 in 5 girls and young women, 30 to 50% among the infertility patients. The risk of glucose intolerance among women with PCOS is 5 to 10-fold higher than normal, and about 30 to 40% of patients with PCOS have impaired glucose tolerance. 50 to 65% of PCOS patients are obese. According to NIH criteria, 6 to 8% is the incidence. Rotterdam criteria gives an incidence of 15 to 25%. In Indian Asian urban community, this number is more and seems to be rising for reasons unknown. So it is very important for us to create awareness about PCOS among adolescents and prevent all the complications occurring because of it. Coming to the epidemiology, 20 to 33% of all reproductive age group have PCO, 5 to 10% of all reproductive age group have PCOS, 87% of women with oligomenorrhea, 26% of women with amenorrhea, 50% of them presenting with infertility, and 50% of women with recurrent miscarriages. The most common cause of PCOS are excess androgen, that is male hormone. Excess of insulin triggers ovaries to make more androgens. Other causes are genetic, inflammatory, and lifestyle factors. So PCOS is a multifactorial disease, and it affects in pregnancy, in utero, adolescence, and adulthood. So there's a two-hit hypothesis for the pathophysiology of PCOS. Development of hyperandrogenism is the first hit. The second hit is hyperandrogenism begetting more hyperandrogenism, which is the main hormone leading to the various complications of PCOS. It is a multifactorial disease, so there are heritable traits, that is in a maternal PCOS, 25% risk among daughters, polycystic ovarian syndrome inherited as autosomal dominant, hyperandrogenemia leading to serum testosterone, sex hormone binding globulin, metabolic syndrome, a cluster of central obesity, hyperglycemia, dyslipidemia, and hypertension, and its core pathogenetic constituents, insulin resistance and obesity, have heritable components. Then there are gene variants, intrauterine environment of congenital virilization and disturbed fetal nutrition. Postnatal environment, epigenetics, a number of GWAs in Chinese and Caucasian subjects have identified the LH choriogonadotrophin receptor as susceptibility gene for PCOS. So how does a PCOS girl presents to us? She presents with most common symptom of irregular periods. Either there is less of bleeding or she won't have periods for 2, 3, 4, and sometimes few of the patients have presented with just a single cycle of periods in one whole year. So there's hirsutism, acne, infertility, polycystic ovaries in the ultrasound, mood disorders and depression, acanthosis nigricans, obesity, and alopecia. So why discussing diagnosis in adolescence is important? Because the diagnostic criteria in adolescence is very different from what we have for adults. According to the international consensus diagnostic criteria for PCOS, otherwise unexplained combination of abnormal uterine bleeding pattern, that is abnormal for age for gynec age, persistent symptoms for 1 or 2 years after the menarche starts, evidence of hyperandrogenism, that is persistent testosterone elevation above adult norms in a reliable reference lab, is the best evidence. Moderate severe hirsutism is clinical evidence of hyperandrogenism. Moderate to severe inflammatory acne vulgaris is an indication to test for hyperandrogenemia. So according to the ASHRAE guidelines, all three criteria, that is irregular periods, multiple cysts, and high androgen should be present to label a girl as PCOS. Coming to the complications, it leads to infertility, endometrial cancer, diabetes, heart disease, hypertension, dyslipidemia, sleeping apnea, anxiety and depression, strokes, weight gain, and miscarriage. Management of PCOS is multifactorial. The most first line treatment for PCOS is lifestyle modifications in adolescents. So in the lifestyle modifications, today we'll be discussing about diet. It is healthy food pyramid, vitamin D, exercise for PCOS, say no to alcohol, no to smoking, say no to plastics, a good sleep, and avoidance of gadgets. So according to the various guidelines, first line therapy is indicated for PCOS management in adolescent girls. Healthy lifestyle, healthy eating, regular physical activity to excess weight gain prevention is important for all women with PCOS regardless of weight. Excess weight, aim for 5 to 10% weight loss, yields significant clinical improvements over 6 months. No specific diet, general energy deficit of 30%. Exercise for prevention of weight gain, moderate intensity, that is more than equal to 150 minutes per week or vigorous more than 75 minutes per week is recommended. Exercise for weight loss is moderate in intensity, more than 250 minutes per week or vigorous more than 150 minutes per week. Behavioral strategies include goal setting, self-monitoring, slower eating, etc. A personalized diet chart is a must for PCOS patients. Diet of PCOS key points are weight reducing diet, anti-inflammatory. It should increase insulin sensitivity, rich in calcium and multivitamins, good for ovulation, and should increase HDL and decrease LDL cholesterol levels. It is generally recommended to spread the calories throughout the day by having 5 to 6 small meals. This keeps the metabolism humming and reduces craving for sweets and starches, which is very common among women with PCOS. Optimal meal patterns are consume breakfast within 1 hour of waking, Snack 2 to 3 hours later, eat lunch 2 hours later, another snack in 2 to 3 hours later, and dinner 2 hours later. Lots of leafy green vegetables focus on whole foods and source of protein like fish, eggs, and chicken breast. Spices like turmeric, cinnamon, fenugreek, and ginger that are anti-inflammatory and believed to help with insulin resistance. There's a multifaceted benefits of proteins in diet. Proteins lead to muscle strength. They are anti-inflammatory. They promote bone growth in adolescents, antioxidative stress, antimicrobial, regulatory, anti-diabetic, anti-hypertensive, cholesterol lowering, anti-cancer, and they have improved cognitive function. Coming to fruits, fruits low in fructose are rich in fiber are best. Grapefruits, clementines, lime, lemon, raspberries, blackberries, oranges, etc. are very good for PCOS patients. Healthy fats means food like avocado, salmon, mackerel, sardines, butter, and olive oil. Increasing healthy fats in your diet is a great way to keep you satiated and can help your body absorb vitamins A, D, E, and K. Calcium and vitamin D are important as calcium plays an important role in egg maturation and follicle development in the ovaries. Vitamin D is essential for promoting calcium absorption from food in the intestine. In addition, low levels of vitamin D and have been associated with other problems related to PCOS, including infertility, weight gain, and insulin resistance. Vitamin B helps maintain normal blood sugar levels. Vitamin B5 helps with weight loss due to its ability to control fat and metabolism. Vitamin B6 plays a critical role in maintaining a woman's hormonal balance and fertility. It is also needed for proper absorption of zinc in the intestines. So we have latest ICMR guidelines which suggest the portion of macro and micronutrients in young girls in various age groups. There are certain foods which have to be avoided in PCOS, like high GI foods, sugar, bakery products, and candies, dairy products like butter, cheese, full cream milk, unhealthy fats like ghee, coconut oil, and dalda, caffeine, alcohol, processed food, and table salts. Physical exercise for 40 to 60 minutes in PCOS helps reduce body fat. It increases lifespan, oxygenates body, strengthens muscles, manages chronic pain, wards off viruses, reduces diabetes risk, strengthens heart, and clears arteries and boosts mood. It maintains mobility, improves memory, improves coordination, strengthens bones, improves complexion, detoxifies body, decreases stress, boosts immune system, lowers blood pressure, and reduces cancer risk. Walking in the PCOS patients is easy on the bones. It increases circulation, keeps your heart pumping, lowers blood sugar levels, strengthens your lower back, reduces stress and anxiety, helps you maintain a healthy weight, and keeps you alive. Similarly, yoga in PCOS increases the flexibility of the body to rectify glandular defects and balance hormonal secretions in order to control the breaths, to balance the body and mind. It withdraws the mind from undesirable thinking, to aid in cure and protection from diseases, to improve stress levels, and to prepare the mind for subtler and higher meditations. Cycling and PCOS, it relieves stress, reduces risk of heart disease, improves metabolism, gives you legs of steel, burns calories, not fuel, strengthens your immune system. Similarly, swimming increases flexibility, reduces joint pain, improves mobility, builds strength, tone muscles, strengthens lungs, reduces weight, improves mood, relieves stress, and sleep better. So overall, we see the impact of diet and exercise in PCOS is in patients with PCOS who are obese and have endocrine metabolism, parameters markedly improve after 4 to 12 weeks of dietary restriction. Their SHBG levels rise and free testosterone level falls by twofold. Serum insulin and IGF-1 levels also decrease. Weight loss in patients with PCOS who are obese is associated with the reduction of hirsutism and the return of ovulatory cycles in 30% of women. So the relationship between the adolescent diet and chronic disease risk is based on the assumption that eating behaviors are learned and solidified during childhood and adolescence are maintained in adulthood. So mental and emotional health also get impacted in PCOS. They are just as important as physical health. Depression and anxiety are common in women with PCOS but are often overlooked and therefore left untreated. We must counsel these patients. Screening in adolescents for PCOS. Screening should be done for obesity and overweight, hypertension, cardiovascular risk, metabolic syndrome, diabetes, obstructive sleep apnea, emotional well-being, eating disorders, and body image issues. So the take-home message of my talk today is health professionals' interactions around healthy lifestyle, including diet and exercise, need to be respectful, patient-centered, and to value women's individualized health, healthy lifestyle preference, and cultural, socioeconomic, and ethnic differences. Health professionals need to also consider personal sensitivities, marginalization, and potential weight-related stigma. Lifestyle interventions and behavioral strategies such as goal setting, self-monitoring stimulus control, problem solving, assertiveness training, slower eating, reinforcing changes and relapse prevention to optimize weight management, healthy lifestyle, and emotional well-being in women with PCOS. So the acronym for SMART is specific, measurable, achievable, realistic, and timely goal setting and self-monitoring can enable achievement of realistic lifestyle goals. Psychological factors such as anxiety and depressive symptoms, body image concerns, and disordered eating need consideration and management to optimize engagement and adherence to lifestyle interventions. Thank you.
Thank you, ma'am. Thank you very much for this excellent talk. Ma'am, the questions which would be there from the audiences, we will take all the questions at the end, if you allow us.
Yeah.
Uh, so I'm sharing my screen. Our next speaker is Dr. Badrinaryanan. Sir is MBBS and MD General Medicine and DM Cardiology. Senior Consultant Cardiologist, Apollo Hospitals, Hyderabad. Visiting Consultant to BHEL, Fellowship, FICC, FESC, and FIAMS. Engaged in actively as speaker in many national and international conferences and awarded by many NGOs. So with this, I request Sir for his next talk on PCOS and cardiovascular diseases. Over to you, sir.
Thank you, Dr. Prachi. Yeah, good evening, everybody, faculty, Dr. Payal, Dr. Prachi, Dr. Meera, Dr. Kamal, and Dr. Ashish, who may joining later. Actually, it is a nice topic where the multifactorial, multidisciplinary approach is required for well-being of a futurely growing lady or female. Dr. Payal actually has spoken very well on the lifestyle modification and lessened my work to maximum extent. Anyway, there may be some overlap may be there, some additional thing may be there. Okay, one my polycystic ovarian syndrome or disease and cardiovascular disease. You see, one is polycystic ovarian syndrome is an already discussed endocrinopathy resulting in some problem which causes some system disorders, some non-reproductive system disorders, among which cardiovascular disease is the main, because you know cardiovascular disease is the leading cause of death not only in India but in the universe. You know, in the US, the stat 1 in 5 due to cardiovascular disease, and 1 person dies every 36 seconds due to cardiovascular disease, and in total 6,55,000 people died because of cardiovascular disease in US till now, the recent statistics. So how important to a cardiovascular disease, which is such a high morbidity and mortality value, if you prevent at any step, as described by Dr. Payal, we can save human life, giving a very qualitative and quantitative having life of society. See, already she has described what the definition of PCOD or PCOS These are menstrual irregularity and hyperadrenalism and hirsutism, acne. I should not repeat those things. These are all accepted criteria for diagnosis of PCOD.
Sorry, sir, your
Then
slides are not moving, sir. Can you just, the slides are not moving, sir. Can you just go for the full screen?
now,
So it's not moving, sir. You go to this full screen.
yeah. One second. I'm doing. Slide more. Now is okay?
Oh, sir. It is actually static. You okay, sir? You again do it, sir. I will just stop share. Again, share the screen, sir.
Okay, I will do it next.
Yeah, it is coming now, sir.
Okay, right. Is okay?
Yeah, it is coming fine, sir.
Yeah. See, now we'll come to the part. You see, all the accepted criteria. Epidemiology already described. It is a quite considerable number of people with different symptoms, from gynecology symptom or reproductive system symptom to general symptom. People who can diagnose PCOD. Then come to, so such a huge number we are having. We have to give them a good quality of life. See, what are the pathophysiology of the PCOS? Exact cause is not known. Evidence supports the hypothesis that decreased sensitivity, consequent hyperinsulinemia are the pivotal problem pathogen of PCOD. Evidence of autosomal transmission related to strong clustering, as Dr. Payal already told, 25% mothers will have PCOD. Possible hypothalamic defect, a post-receptor defect in adipose tissue has been attributed, which is responsible for dyslipidemia. I will come slide by slide again. See, this is the slide. This hypothalamus was described as a defect which lead to anterior pituitary hormone released to luteinizing hormone over follicular stimulating hormone, which causes increased androgens, which causes hyperinsulinism, all of the male hirsutism, acanthosis nigricans, and which also responsible and insulin resistance, which doublers later on with the diabetes mellitus. These are usual features, but in why I've shown this feature, this is typical obesity which comes under our purview to tackle to decrease the incidence of cardiovascular disease. This is obesity. Basically, it is obesity or abdominal obesity or apple-shaped obesity, which is a higher risk than global obesity. She has already described clinical features of in adolescence PCOD, no typical features, but obesity may be a signaling and irregular cycles may be another signaling features. She may develop PCOD, more concerning hyperadenoganism and peripubertal girls with puberty before age of 8 suspect PCOD. Now again I told the features, you may have a reproductive system, you may have a non-reproductive system. These are all reproductive systems symptoms, anovulatory symptoms like erratic cycles, primary amenorrhea, oligomenorrhea, hirsutism, acne, male petty hair loss. Now come the non-reproductive group. Obesity, mainly abdominal type or truncal obesity, 40 to 80% of BMI more than 30. I will come later on as the slides goes on what the obesity definition, how to tackle, and insulin resistance, which is the main pathology behind all the symptoms are affecting, causing diabetes to heart disease and diabetes. And this is the infertility, pregnancy with spontaneous miscarriage, abortion can occur. Next, you see, these are all listed by Dr. Payal, endometrial hyperplasia cancer. This is our topic, dyslipidemia, low HDL, high triglyceride, not LDL. These are typical of PCOD. You may have LDL high because of heavy fatty diet or a high cholesterol diet. But dyslipidemia in PCOD typically you have low HDL, high triglyceride. This will occur in 70% of PCOD cases. This accounting to metabolic syndrome, which is prevalent to 30 to 40% of PCOD patients. Either more non-alcoholic fatty liver disease, coronary disease. You see another risk factor, sleep apnea, depression, anxiety, with psychotic features, and usually this PCOD patient, they are the binge eaters. They take a lot of food. That is a thrust because of this hyperinsulin reaction. You have to check the eating habit, change the eating habit as he describes goal, weight goal, obesity goal, everything to be fixed so that they will try to achieve that goals. These are the few non-productive reproductive system symptoms. So this will now, these are diagnosis is already described from symptoms, ultrasound and blood examination, biochemical examination. Now we will come to subject of cardiovascular disease. What is the pathophysiology? We have discussed by discussion hyperinsulinism mainly, which affects have an increased activity of hepatic lipase, which is responsible for your dyslipidemia, altered lipolytic response to insulin, impaired fibrinolytic activity due to increased circulatory levels of PAI1, that is plasminogen activator inhibitor 1, which causes blood to more coagulate. So which coagulates in the coronary artery, which causes coronary disease. So these are the basic pathophysiologic mechanism. See the diabetes, we already there is a topic, Dr. Ashish Chauhan, a good speaker, he will tell on the diabetes and other things we'll discuss. I'm skipping this topic. Now, what are the, you see, coronary disease, I told, though is a major cause or number one cause of death throughout the universe, is infective agent or something. It is caused or having prevalence, the clustering of risk factors, which is known as risk factors, which causes coronary disease. As the patient, as the having more and more risk factors, he or she more prone for the heart disease. So what are the risk factors? PCOD we have discussed. They will have, you see, we have seen obesity, main feature, hyperinsulinism, main feature, dyslipidemia, depression, onset of diabetes. These all include metabolic syndrome in the criteria. Additional modern risk factor is smoking. You see, nowadays, lot of women during that period age, because of anxiety, professional stress, are influenced by the society, they jump to smoking. You know, the developed country like UK, the highest number of lady smokers are increasing numbers in UK, though they suffer a lot of other diseases in addition to coronary disease. And excess alcoholism. I will come later on, or I will give a word why I told excess alcoholism. You see, nowadays so many media or internet has come, modern alcohol protects the heart. So that is the peculiar mechanism of alcoholism. Moderate to excessive or heavy drinking. Moderate drinking, excessive or heavy drinking causes the disease. This is the pathophysiology of alcohol causing a human body reaction. How it reacts is a really very difficult subject, but excessive or heavy alcoholism is a risk factor for a heart disease. At the same time, it increases the mortality and morbidity. It is also a risk factor for hypertension. So this is the metabolic syndrome. We have discussed what are the things, components, hypertension, dyslipidemia, same high triglyceride, less HDL, the peculiar for dyslipidemia in PCOD patients. Obesity means diabetes, requirement for 3 of the above. So these 3 usually associated with PCOD, sometimes associated with hypertension, consequent upon these risk factors. See, another recognize PCOS patients are at a high risk for developing metabolic syndrome. You have to detect, then take measures to delay or arrest metabolic sequelae. Otherwise, patient, you think of PCOD, they will suffer coronary artery disease, different manifestations like angina, unstable angina, or MI, maybe arrhythmia, or sometimes maybe have a cardiomyopathy, going to premature death. See, at the end, this is with basic, this is the background of pathophysiology and risk factors. Cardiovascular disease occurs in PCOS patient. How much? 7-fold increased risk of myocardial infarction. PCOS patients, I told LDL, HDL lower, but levels increase LDL because of dietary habit, but peculiarly triglyceride is elevated in PCOD patients. These are normal artery, the injured artery, then cause the plaque or cholesterol deposit, then the plaque rupture, platelet aggregation, then fibrin aggregation, causing total occlusion, leading heart attack. So what are the risk factors in your level? You can have smoking, high blood pressure, you can cholesterol, overweight, obesity, physical inactivity. She describes so nicely diabetes, pre-diabetes, and metabolic syndrome. If you care of these risk factors, you will prevent development of the metabolic syndrome. So, in addition to what risk factors patients are developing of PCOD, we have other risk factors known as the coronary risk factors. You see, high LDL cholesterol, high fat diet, level may be less, but high fat diet is also risk factor for heart disease. That particular patient of PCOD may be adjust to the high fat diet, we have to avoid. Next, a left ventricular hypertrophy. You do a echo. If left ventricular hypertrophy, if left ventricular muscle is thickened, is also risk factor for future coronary event. Rest things I have discussed. Another important is lipoprotein little a, homocysteine, oxidative stress, age, male gender limit, low socioeconomic status risk factor, family history of LECAD. It may be adjusted with the PCOD patient. This may be why the chart I have given. In addition to the risk factors which will be or which the patient will develop, we have a traditional a society will have. So in addition to those risk factors, if you have these risk factors additional, those patients are more prone to have cardiovascular disease. So individually I will tell, smoking, it increases 50% of the risk factor. High LDL, near 20 to 30% increase the risk factor. High fat diet increases. LV hypertrophy, diabetes increases coronary disease. Physical inactivity. Interesting story of physical inactivity I want to tell you. In 1950, Morris and colleagues first detected what is the level of physical activity when they observed in Western country, the bus drivers are suffering from coronary disease more than the conductors. That is the happiness. Why the drivers are suffered more, not conductors? Because the drivers are always sitting, conductors are moving. So with that, for some 100 studies, they've seen physical activity is definitely a major role. Even they found, like in those who have a physical activity due to interval, leisure activity, that is known as a leisure activity, those who are doing, they suffer less coronary disease. Those executives, those who don't do leisure activity. With this background, the physical inactivity became a risk factor for coronary disease. Now, these are the novel risk factors, oxidative stress means body is inflammatory stage for which the measurement interleukin 6 or C-reactive protein we have to measure. Lipoprotein little a, homocysteine, especially we are at risk of in lipoprotein is the highest incidence or prevalence in our country. There are additional risk factors. So, friends, when you have a patient of PCOD, never look like a PCOD patient. Try to detect, estimate how many risk factor patient will has, and what is the atherosclerotic risk factor, or estimate from column how much probability of heart disease in 10 years risk factor assessment. According to that, multi-factor or multi-directional approach or multi-department approach can mean patient will get benefit. So already this portion has been discussed, that's why I curtailed. The main part of treatment I already repeatedly telling, the lifestyle modification, which includes, usually you say the patient like 3 formula, thanda karo, pair ko shuru karo, means no stress to the brain, no food to the mouth, activity to the foot. So these 3 simple formula, exercise, alter diet composition, and weight loss if you are obese, low fat, low carbohydrate diet is ideal. The exact composition is already described. See, this is heart disease. Can you prevent it or control? You know, prevention is always better than cure. So prevention includes, main part is of heart disease prevention is lifestyle changes, sometimes medication if prescribed by doctor. These are the diets. Either good or bad, you can see an unhealthy diet at a fat and cholesterol increase the risk. Make healthy food choices. You see how much bad, sweet, this thing dry, you should avoid. Next, you see pickles and fried and dry fishes. These are all low salt intake is always advisable. Not only see, low salt intake is an essential component of management of hypertension, irrespective of degree of BP rise. But normally, you know, we are taking 4 to 6 grams of salt per day. Less than 3 is good. 3 to avoid above 4 grams. So what can you do eat? She has given a chart. In summary of eat plenty of fruits and vegetables. Try to eat a variety of fruits and vegetables each day. Choose whole grain foods like whole wheat bread, oatmeal, brown rice. Can be good source of dietary fiber. Eat fish, especially oily fish like salmon, trout, herring, at least twice a week. Limit your intake of saturated and trans fats. The usually fast food have these trans fats. Limit the amount of red meat you eat. Choose red meats and skinless poultry. Choose low-fat dairy products such as skim milk or low-fat yogurt. Limit your intake of beverages and foods with added sugars. Learn about sodium, the common food that have too much of. Compare food labels. Choose the foods with the least amount of sodium from the label or the packet. You can see if you want a small handful of 1 gram ounces of whole nuts or 2 tablespoons of whole nut butter. Drink water instead of dairy drinks. Try adding slices of fruits to your beverages instead of sweetening with sugar. You know already there were so much ads. Avoid aerated drinks which causes not only CAD, some other factor also. Did you know 12 ounces of soda can contain 8 teaspoons, which is harmful for the body? Then we come the inactivity. I told the story of how the physical inactivity medical literature from bus driver to conductor to executives. Now everybody see physical activity combined with good eating, with overeating, excess cholesterol, your risk of heart disease. Now prevention of begins with you, not with the doctor. With you means patient. One step at a time. Replace unhealthy habits with healthier ones. Eat for a healthy heart. Start walking. Try 10 minutes. Add time gradually to reach. That already she told vigorous and moderate vigorous. How much time? 150 minutes or 250 minutes. It is normal. If you want to weight reduction, you make it double. 75, 150 to 150, 250. See, next patient will ask, only walking is sufficient? No. Walking not sufficient. Easy, that is a must. You can, so that is the best. After that, if you walking, if patient doesn't want, you can go cycling next, then smoking, that swimming, next jogging. But best is walking. Anywhere exercise, always compare with walking. The American Heart Association recommend 30 to 6 activity on most of the days of the week. 60 minutes, you can go for 6 days, 30 minutes, 7 days. You cannot have a Sunday off. So exercise helps to control. These are the things I described. Smoking. There is smoking a cigarette per day also. This is papam. One papam also papam you will get punishment. So cigarette means it contains nicotine in any form. Not only people in an OPD we say, are you smoking? No, no, I am not, never tested. When you go detail, are you taking gutka pan? Yes, sir, I take gutka pan. So that is equivalent. So the smoking, not only don't pick up the smoking, you have to ask detail whether a gutka pan, cigar, hookah, snuff powder. In West Bengal and Orissa, there is a paste like gudaku, they will tell. These are all varieties of nicotine. These are all smoking equivalent. You see how much? This is BDs in some country. And one thing I left is suttalu. block. Even ladies, they smoke in keeping the burning point inside the mouth, which is more increasing their cancer risk of the buccal mucosa. So you know how much dangerous. And from corona disease point of view, smoking increases 50%, not only morbid mortality, but also incidence. Doubles your risk of a heart attack. This reduces oxygen in blood, damages blood vessels, contributes to your high blood sugar. These are all risk factors with low levels of HDL. You know HDL is a good HDL, friendly HDL means good LDL, good cholesterol. In layman you say, but never say good cholesterol, maybe prevent they will think of, but up to some extent only. Then what can you do for smoking? This you want to do, not a single cigarette you will allow. Tell your friend that smoking can kill them. Even one here I want to highlight also. These are all I'm thinking of active smoking. There is another term, passive smokers. If you stay amidst the smokers, you are also equally exposed to smoking. Sometimes you are more prone because the regular habitual smokers, they know how to inhale and exhale. You never smoked means if you are exposed to that person, you can inhale, but you cannot exhale. So your lungs and coronary disease risk is more than the active smokers. So both active and passive smokers, that's why all the things are many places don't smoke. Smoking room is there. How much that is benefit, let us see. Now we have discussed obesity. In little additional to that, how will you define obesity? Obesity is defined as global or localized. I told the more risk is with Apple-shaped obesity, Android obesity, or male type is more than the limbs. So the BMI, which is calculated weight in kgs divided by height in meters square, is less than 25 is okay, more than overweight, more than 25 overweight, more than 40 is extreme obese. Another thing, what the ideal weight one should have, patient will ask also. So height in centimeters minus 100 plus or minus 5 kgs will be your, you say this is the average weight you should have. Another parameter, waist circumference. That also says Apple's obesity, male above 104 centimeter, female more than 88 centimeters, they will term as a end obesity or abdominal obesity. Another parameter also, waist hip ratio. That is usually global, waist hip ratio more than 1 is like more than 8.8 also female. But these are the plain, you can say BMI is a global. You can say specifically I written is waist ratio, waist circumference, and waist hip ratio. These are usually the parameters you take in the OPD. Why these figures are important? Figures are important. If you tell the patient, this you are having, this is the ideal thing, she will fix his goal. Achieve that goal. I am going to the next slide. So how will you do the weight reduction program? Overnight you can't do. And it is also not practicable, not also advisable. So ideal weight reduction is 10% of the weight in 6 months. Plan how much body he or she is supposed to have. What is the extra weight? How much reduction? Your plan is 6 months. So decrease calories. How much in food? You have to translate in the food. How much calories? Then the item of the type of food. What type you can have so that you can reduce your weight. So you have to, these are all weight reduction program. Every periodic counseling, there should be a weight reduction clinic. That's why PCOD management should not be dealt by a single person. It should be a multidisciplinary approach from gynecologist, family physician, from cardiologist, dietitian, even physical instructor. They will advise different modes so they will have a quality and quantity of life. Next, discover the stress. You know modern stress, how much they had stress. We maybe sometimes presenting with angina, I have an anxiety, sometimes the depression, sometimes like phobic reaction. Usually there are common manifestations of depression. The stress may be physical, mental, social, economic, and professional. And why I told you they are professional? Untiring work. If you give the software personnel, give 8 p.m., they will work up to 8 a.m. Some small grape. How much professional stress and target-oriented work? There is more stress. So you have to give some leisure hours to reduce the stress. So this is not the platform to discuss how to stress level reduce, but I want to highlight these are the various way or various situations you will have stress, which may impact your mental health, leading to increase the incidence of heart disease. For nowadays, yoga, pranayam, so much of in publicity, how much it help? This will have a positive health feeling. The different type of yoga, she told flexibility, muscle, muscular, other things. For our my approach to the patient for yoga is positive thinking. Yoga, pranayam, they will make you positive think. Don't give to me, I don't give 100% assurance. If you do practice sincerely, you will avoid medicine. Definitely, you will avoid the target. No, these are all additional things. Don't tell 100% every aspect some limited value, because after angioplasty, also patient came to me, sir, I'm now doing yoga pranayam. I want to leave all the medicines. See, there is no study. If you leave medicines and give yoga, no antiplatelet, how many stents? So those gray zone area we should not touch. We should not give a green signal. Do yoga. This is my sincere to all my those are audience. This is an additional thing. You have a positive feeling only. Then an absolute thing. Next, this another. You can lower your heart risk. I told risk factor reduction. Another is manage diabetes, blood pressure, high cholesterol, and living a healthy lifestyle. Take medicine if prescribed. Medicines for these are insulin sensitizing agent nowadays practice. Weight reduction medicine, though first line is not advisable. If gross morbidity doesn't have surgical for medicine, sometime medicine you prescribe, Orlistat I prescribe sometime, but surgical management also there, but have a clinical value, it is not been proven, protection not been proven, but you are subject to patient a surgical risk. So diet, healthy life, sometime medicine, take surgical colleagues help. Next, so appropriate medication, diabetes, hypertension, as per doctor's advice, there is no substitute for it. Regular medical consultation and the definite multidisciplinary approach, these are very vital for PCOD patients to prevent complications or to have a heart disease. This is my conclusion slide. PCOS is commonly encountered, I told, endocrinopathy in women of reproductive age. Healthcare providers need to appreciate that the syndrome is associated with signs morbidity in terms of reproductive as well as non-reproductive events. Recognize these patients. Early recognition, early intervention. Use precautionary measures to prevent cardiovascular disease and also type 2 diabetes. This is my conclusion. One more slide I have, my personal. If a patient is heart disease suspect, this is my 12 points advice to a patient. First is have activity and medication, activity. Next, chest pain, awareness of chest pain over the patient. Ask exercise, control risk factors only one column. Blood sugar, cholesterol, everything managed. Learn ways to be important, another column. Tell your doctor how your chest pain occurs. That is, you should remember, patients should say what is the chest pain quality and how it is relieved. Keep the list of all medicines with you when you are going for a consultation room. Carry the medicine you take and if required, show to a doctor at the time of consultation. Always keep sublingual nitrates, not always, sometimes, but I written always to only make the aware. Share your condition medication with your family members and friends. They can provide timely help. Never hide you are a cardiac patient. Never hide to tell that I am a heart patient. I have to take these medicines and I am taking. Not to be biased, I told, by false advertisement, unscientific or unproven advices like Ayush, Ayurvedic, this may protect your heart. Be careful. Practice taking low salt and oil. Diet with plenty of fiber daily. This is usually advisable for any heart patient for a primary and secondary prevention. Thank you for a child. Sincere thanks my audience. Anything, question and doubt, I can answer at any moment. Thank the organizers also, Dr. Payal especially.
Yes, sir. Thank you very much. Thank you for your talk. So we will take all the questions at the end of the webinar, if you allow.
Thank you.
Right, sir. I'm sharing my screen. Our next speaker is Dr. Ashish Chauhan. Sir is a MBBS MD Internal Medicine, Senior Consultant Specialist in Diabetes and Adult Immunization Expert from Apollo Hospital, Hyderabad. Specialized training in adult immunization. Fellowship in Diabetes and the Ages of Dr. Nihal Thomas from CMC Vellore. Has been an active speaker in various media platforms. He'll talk on national Hindi channel Shubha Sandesh, where he has interviewed Padma awardee Dr. D. Nageshwar Rao, Dr. Sunil Chandi, Director CMC Vellore, and Padma Shri Dr. Umesh Bharti. How to avoid lawsuits and stress management for doctors have made him popular globally. Actively engaged in teaching students from medical fraternity. His blessed lectures have been well liked by medical students worldwide as well as the nursing graduates. Dr. Ashish Chauhan is an avid reader and a socialite, where along with the Olympian Saina Nehwal and Gagan Naran, he has spearheaded vaccination camps among orphans, along with countless food distribution camps. His organization, Nathan's Learning Forum, works in the field of academics, where through collaboration for medical, nursing, and other educational institutions have been enormously benefited. So, with this, may I request and invite Dr. Ashish Chauhan for his talk on insulin resistance in PCOS. Over to you, sir.
Very good evening to everybody. It is a very blessed time, and thanks for giving this opportunity to be a part of it. Can you hear me? Can I get some response?
Yes, sir, we can hear you.
Okay, fantastic. I would want to do the screen sharing so that the slide can be shared. And I've had enjoyed lovely session of Dr. Badrinaryanan sir, where the he has done my part very easy, and so majority of my discussion is actually what he's already shared it out. So that makes his things easy for me. And here is what I share my screen sharing. So start now. Allow permissions. Can you see the screen? Is that fine?
So, not yet.
Are the slides be seen?
So, not yet.
Not yet. Okay. Just a second. Sometimes I think the new session for in the medical fraternity should be that, how do we handle this technology should be important. The sharing. Is it fine now? Still not?
No, sir, still not. Sir, can you open your slide deck and then start sharing?
Sorry?
Yes, sir. Now we can see your slides. But
is this better? Can you see my slides?
no, sir, not yet.
We are seeing your WhatsApp messages.
connect audio. Oh. Hmm.
So please open your slides first and then you start share.
First, I open up the slides. My slides are open.
Okay. So can you do a presentation mode?
So I have to do the slides in the presentation mode. Has it come into the presentation mode?
So now I can see your slides. Yes.
You can see the slide. So is it okay? Can we continue with this?
Okay, sir. Fine.
Sir, is it possible for you to send this slide deck in this 19th webinar group?
I can do that.
Yeah,
I
please share it to
can.
me. I'll open it in the form of a PPT.
That's
Okay, and
fantastic.
then you can just let me know when to move forward, right?
Wait a second. I think something is coming. Not really.
Yeah, it should come actually. Presentation PPT it is showing.
Anyhow, I'll just share this to the group. Yeah. You got it?
Yeah, I got it.
Are you sharing for me?
I'm doing that. Just a second.
Okay. मिलेगा.
Yeah, doctor, are you able to see it?
Yes, perfectly. They look good, and amazingly, my name is also there. So that sounds good.
Yeah. Let's continue.
Okay. Do you think I will be able to change the slides? Not really. I think the slide control is on your hands.
Yeah, it is in my hand. So what you can do is you just let me know. Next, I'll just move on.
Oh, fantastic. I would say 19 years back, I gave all the controls of my life in my wife's hands. So it's absolutely fine with me right now. So slide control is in somebody else's hands. So yes, we will go. Can we just see the slides? Insulin resistance and metabolic syndrome in PCOS. I would want to congratulate the whole team and especially Payal and Dr. Badrinaryanan because very meaningful topic. A good number of young women at this time are struggling with this. It has got a physical implications, got a mental associations and emotional attachments to this disease. Next slide, please. Next slide, please.
Is it not coming?
Yeah, that's better. Pathophysiology, it's possible hypothalamic defect. A post-receptor defect in adipose tissue has been identified, and insulin resistance, there is no doubt about it, and multiple times the same thing can be repeated, and we can work on it more and more. Next, please.
I don't know why it is stuck up. Even mine is stuck.
The suggestion of a presence of hypothalamic defect has been postulated. There are elevated LH levels, hyperandrogenism, and anovulation. These are the three big things which we need to consider it out. And we need to know that for all the practical purposes. Elevated LH levels, hyperandrogenism, and anovulation. Next, please. Causes of PCOS. I think this is a very lovely slide for all of us to understand. Obesity, androgen excess, inflammation, genetic, and insulin resistance. So the thing which we need to understand is a very, very old and lovely saying is the obesity doesn't run in the family. The problem is nobody runs in the family. And that's what we need to promote it out. Especially this lockdown has made us more of a couch potato. So we need to promote, how do we fight out with obesity in our given situation to us. Next, please. How PCOS may present in patients endocrine abnormalities like elevated LH levels and normal FSH level, increased testosterone activities often expressed as free androgen index, insulin resistance with compensatory hyperinsulinemia. Next, please. Next, please. No, yeah. Now this is where if you actually see it out, because I believe there are a lot of youngsters also who are watching the program or the presentation, they will understand. There are 7 A's which we need to remember: acanthosis nigricans, alopecia, amenorrhea, anovulatory infertility, and androgen excess. These are the few things which we need to. And central obesity can be restructured and written as abdominal obesity, and hirsutism will be abnormal hair growth. So if we take these proper A's, probably PCOS can be easily understood. Acanthosis nigricans, alopecia, amenorrhea, anovulatory infertility, abdominal obesity, abnormal hair growth. Next, please. This is what we can see. Very, very obvious. Acne is present, which I forgot to add. So acne and alopecia, acanthosis nigricans, a very lovely picture which is shown out here. And on the head you can see there is alopecia, and then there is hirsutism. One of the most important picture for people to understand what is PCOS all about is this slide, which I would want people to focus upon. Next, please. Insulin resistance plays a pathogenic role in the metabolic syndrome. Metabolic syndrome is more prevalent in women with PCOS than in general US population. One study found that the prevalence of metabolic syndrome in women with PCOS was 43%. And next, please. And these are the 5 features which we require it. Why I call it 5? Because obviously dyslipidemia can be divided into 2 things, as triglyceride and HDL. This is something which we need to remember. Hypertension, dyslipidemia, obesity, and glucose. For all my youngsters who are around, I would want to tell you again an acronym for you to remember. For a metabolic syndrome, the acronym is METAB, M-E-T-A-B. M is for men's HDL, which is less, which should be more than, if it is less than 50. M is for men HDL. E is for elevated. T is for triglycerides. A is for abdominal circumference. B is for blood sugar. So E is for elevated blood pressure, T is triglycerides, A is abdominal girth, and B is blood sugar. If you can remember, it becomes a bit easy for us to remember. Any 3 of the above is available, then probably the person has got metabolic syndrome. Next, please. And this is where the recognizes that PCOS patients are at high risk for developing metabolic syndrome, and plasma reduced blood flow is there, enlarged area, and that is where the cardiovascular risk comes. Dr. Badrinaryanan sir has talked fantastic over it. I don't need to go about it. Next, please. And injured arteries, we can see because of the lowered levels of HDL and increased levels of LDL, as well as other things, there is something called as high chances of cardiovascular risk profile. And rather, it's been told very clear-cut, there are 7 times high of myocardial infarction, which I believe is actually underestimated. There are much, much more than that. Next, please. Metabolic syndrome population have increased prevalence of glucose intolerance. That's why if we come to the crux of it, We need to be working on diabetes. We need to be working on hypertension. We need to be working about the low intake of sodium as well as low intake of sugar. Prognosis to the type 2 diabetes mellitus has been given out here, that it's because of obesity and sedentary lifestyle. There is insulin resistance, which causes impaired glucose tolerance, which causes increased beta cell production of insulin and beta cell exhaustion. So there is hyperinsulinism, and finally inadequate insulin for the degrees of insulin resistance in type 2 diabetes mellitus. So probably there is a huge insulin, but that cannot be used for the peripheral conversion of the glucose. That's why there is diabetes mellitus. Next, please. Current treatment looks very easy slide and something which does not get us our fees. You need to understand that today patient appears to be very smart, but they're the most dumb in the given scenario, and we need to understand that and try to talk it out to them. If they come to you and you tell them that, thanks for paying the fee of 600 to 800 or 1000, whatever the fee which we charge, and we tell them the only treatment which you require is stop chicken, mutton, and rice and go for exercise every day, 1 hour. Who listens? That's a dichotomy we have it, that patients want the best treatment, but they do not take the best treatment. They always go for the second best, which is medicines, which are equally important. We all need to tell them it's all about medication and meditation as well as following instructions. Unfortunately, we find it tough to teach it to our children as well as to our patients, and it's an art which we need to learn it every day with every patient. Next, please. Current treatment, other than the most important thing which I have told you, is diet and exercises. Insulin sensitizing agents like metformin. One of the biggest blessing to mankind with the diabetes is metformin, which should be taken as if there's something which does not cause even hypoglycemia if taken alone. Along with metformin, thiazolidinediones like troglitazone, pioglitazone, rosiglitazone, these are the examples of thiazolidinediones, but only pioglitazone is available. Troglitazone has been obviously banned because of liver problems, and rosiglitazone because of heart issues. Weight loss medications can be thought about it. Phentermine, sibutramine, I don't think they're available. Orally state is very, very easily available, especially if people are going for binge eating. Suddenly, Diwali time, they want to have 1 or 2 laddus or, motichurs, something which distracts them. Probably one orally state 60 milligrams can help them out. Next, please. Take home message. I love to leave the PCOS as one of the acronym for all of us to remember. This is my last slide. P is for precautions to prevent cardiovascular complications of diabetes mellitus. Heart attack kills suddenly. Heart attack kills suddenly, but it comes very slowly. See Dr. Badrinaryanan and any of the cardiologists before it is too late. Prevention is the answer. Sometimes prevention is the only answer. Yesterday morning, I had declared one 29 years old boy dead in our, when he had presented to emergency, because there were no chances. He was kind of brought dead. And the only reason was smoking as well as overeating. Prevention is the answer. C is consistently lifestyle modification. With the biryani eating population around, probably a tough call, but yes, we need to talk about it. O is obesity mixed with weight loss plans, and regimens are very important. Probably a keto diet is a dangerous alternative to look into it. Obesity has to be handled properly with the proper guidelines. S is specific issues to be addressed. Acne can be mentally traumatic. Hirsutism as well as alopecia needs to be addressed by specific specialty. We all have to understand that we don't need to become, one-stop shop for every problem of a patient. We all need to learn to refer patient. And that's how we gain patients' confidence. The time we're trying to do too much things. I've seen a pulmonologist trying to give the diabetes medications and a lot of various stuff. The issue is finally patient knows where the things are going wrong. You and me have the duty to refer the patient for proper treatment to the right kind of doctors, and that's what we need to do it in the present day of era where the Consumer Protection Act is kind of on everybody's tip of the tongue. With these few words, I would be very happy to finish my presentation, and I would tell everybody that stay happy, stay healthy, and stay blessed always. A big thanks to everyone who gave their kind attention to listening to me, as well as to Payal and the whole team of PCOS for doing this seminar. Thank you, and may God bless you all. Thank you.
Thank you, sir. Thank you very much. Especially those acronyms were really, really useful and easy to understand. So thank you very much, sir.
Thank you.
We will go to next speaker. Again, I'm sharing my screen. Dr. Meera, who is MS, DTO and DNB Ops and Gynecology, FNB Reproductive Medicine Oasis Fertility Hyderabad, co-founder MM Academy New Delhi, special interest in PCOS, male infertility, high-risk pregnancy. Ma'am has more than 20 publications in scientific journals, and Ma'am is the editorial board member of Indian Journal of Case Reports. So with this, may I request Ma'am to deliver her talk on PCOS and infertility. Over to you, Ma'am. Thank you very much.
मीरा मैम माइक हटा लो.
Yeah, hi.
Yeah.
Good evening, everyone. Thank you, Dr. Payal, for making me a part of this PCOS webinar, which is quite interesting with such important topics. So, as we have already discussed about the adolescent age group, about the cardiovascular risk factors and how do we prevent them, and then about the insulin resistance. Now, I'll be coming over to a very important topic concerned with polycystic ovarian syndrome, which is infertility. So, in our OPDs,
Dr. Meera, unmute yourself, please.
Meera ma'am, you are unmute. So you are on mute. Yeah, correct.
is it fine now?
Yes, it's fine.
Okay. So as we know that polycystic ovarian syndrome, it is a heterogeneous disorder. It can present in a younger age group with menstrual disorders, with hirsutism, and also with infertility. Whereas in the older age group, it can present with type 2 diabetes mellitus. Some patients can present with endometrial cancer and also with cardiovascular disease. So we'll be discussing about infertility, which is our topic today. So as we know that most of the patients who come to us in our outpatient department are as an infertile population is PCOS. And how do we diagnose that? That is an important thing. So first, we have different diagnostic criteria for polycystic ovarian syndrome. And the most commonly, which is now used, is the NIH 2012 extension of the Rotterdam criteria 2003. So as we very well know, that in case of polycystic ovarian syndrome, we need to see whether the female has oligo or anovulation, whether she has hyperandrogenism and polycystic ovarian morphology. So in case the female has either two of any of these three criteria, she's been diagnosed as polycystic ovarian syndrome. How do we get to know whether she has oligoanovulation? In a female who has irregular cycles is supposed to have oligoanovulation. And in a reproductive age group female, the criteria which is followed is by Eshrate 2018, where if the female has the intercycle length of less than 21 days or more than 35 days or more than 90 days for any one cycle or less than 8 cycles per year, that is diagnostic of irregular cycles or oligoanovulation. So I'll just repeat it once again. In case the female has intercycle length of less than 21 days, more than 35 days, more than 90 days for any one cycle or less than 8 cycles per year, that is suggestive of irregular cycles, and therefore we can diagnose it as a case of oligoanovulation. So first of all this, then secondly coming over to hyperandrogenism. Clinically, hyperandrogenism can present as acne, it can present as hirsutism, and it can also present as alopecia. So that is the clinical hyperandrogenism. Now, in case a female does not have clinical features of hyperandrogenism, we need to look for biochemical hyperandrogenism. So for biochemical hyperandrogenism, we need to calculate the free androgen index, which is basically total testosterone divided by the sex hormone binding globulin divided by into 100. So in case this free androgen index, it is elevated, that is suggestive of biochemical hyperandrogenism. So to diagnose polycystic ovarian syndrome, we look for irregular cycles, we look for hyperandrogenism, which can be either clinical hyperandrogenism or biochemical hyperandrogenism, which is diagnosed with free androgen index. And then third is polycystic ovarian morphology. So polycystic ovarian morphology, as Dr. Payal has already told us, that we cannot diagnose it with ultrasound. So in any female who is less than 8 years post-menarche, it is not suggestive that we use this ultrasound criteria for the diagnosis of polycystic ovarian syndrome. In those cases, we only use hyperandrogenism, and also which can be either clinical or biochemical, and the irregular cycles, which has a different diagnostic criteria. And in case of a fertile age group or a reproductive age group female, in that case, we need to see the polycystic ovarian morphology also. Till now, what we were using is the Rodatine criteria, in which we were taking the number of follicles as more than equal to 12. But now it has changed. Why has it changed? Is because our technology has changed now. The frequency bandwidth, what we are using, is much higher than before. So it has been revised. Now, in case with a transvaginal scan, where the transvaginal bandwidth has around more than 8 megahertz frequency, we need to use 20 follicles in either ovary as the criteria for the diagnosis of PCOM. So, polycystic ovarian morphology, we diagnose if the female has more than 20 follicles in a transvaginal scan in either of the ovaries. And in the transvaginal scan, what we are using has a lower bandwidth frequency. Or in case we are doing a transabdominal scan, then we use the ovarian volume, which is more than equal to 10 cc, which can be suggestive of polycystic ovarian morphology. So we see all these three things, whether the female has irregular cycles, or if the female has clinical or biochemical hyperandrogenism and polycystic ovarian morphology. In case any of these three things are present, then we can diagnose it as a case of any two of these three. If they are present, then we diagnose it as a case of PCOS. Now, recently, for infertility, from an infertility perspective, and also from the cardiovascular risk and the metabolic syndrome risk point of view, phenotypes have come up. So we have 4 phenotypes now. It is phenotype A, B, C, and D. In case of phenotype A, all the features, that is hyperandrogenism, along with ovulatory dysfunction and PCOM, all these three are present. In type B category, the polycystic ovarian morphology is absent. So the female has only hyperandrogenism and ovulatory dysfunction. In type C, the female will not have irregular cycles. She will be having regular cycles, and rest 2 features will be present. Whereas in type D, hyperandrogenism will be absent. So these are the 4 phenotypes, and I usually remember it with the mnemonic that in A, all will be present. B will be bizarre, in which the polycystic ovarian morphology will itself be absent. C is in which the cycles are regular, that is cycles are present. And D is D for dashing, that is the female does not have hyperandrogenism. So these are the 4 phenotypes, and the importance of these phenotypes is that type A and type B, both of these phenotypes, they pose a female more at risk of metabolic syndrome. They are at a poor prognosis in terms of fertility, in terms of conception, and also the risks in the pregnancy are higher. So type A and type B, where hyperandrogenism is present and the cycles are irregular, there are more chances that the female can have infertility, can have metabolic syndrome, can have complications during pregnancy. Whereas type C and type D, they fare better. You can tell them that yes, your prognosis is fairer in comparison to type A and type B. Now, coming over to the workup of a female who comes to us with infertility, first of all, we take the history and we diagnose, first of all, whether she has PCOS or not on the basis of the criteria we just discussed. Second is, we look at the age of the female, because age is very important in terms of us knowing or prognosticating her in terms of infertility. Third is the duration of infertility and the BMI of the female, which are also very important criteria. And then we go on to the treatment cycles which she has already taken. So we'll ask her what medications is she on, whether in the treatment cycles which she has taken in the past, if she has had no dominant follicle, which is a risk in case of PCOS, that is, she does not respond to medications, or if she hyperstimulated in those cycles, or the follicle did form, but it did not rupture, that is luteinized unruptured follicle. And if during the cycle she had a thin endometrium. So these are some specific risks or specific things which can happen in a patient whom we are stimulating for fertility, because they have, in case they have irregular cycles and they are not forming one follicle or dominant follicle in each cycle, so they don't have the chances of a pregnancy. So in these patients where we are treating them for a pregnancy or for a fertility, in those cases we need to see what treatment cycles has she taken in the past, and if she had any of these things which she is at more risk in view of PCOS. So OHSS, there is no dominant follicle, there was resistance. Third is she had a follicle and it did not rupture, unruptured follicle syndrome, the luteinized unruptured follicle, and the thin endometrium. And then last but not the least is we have to see if she has had ovarian drilling in the past. Why is it important is, one, in case she has had ovarian drilling in the past, she should not go for this procedure in future, even if the ovarian drilling has not worked for her. So usually why do we do a ovarian drilling is just to see in case she had a resistance in the past and she did not form a follicle, if she can form a follicle in future. So ovarian drilling helps in terms of she getting a regular cycle or forming a follicle, dominant follicle with medications. But it should not be repeated in spite of what it has done to her, because it can lead to low ovarian reserve. So the different investigations which we do in these cases is utmost important is TSH and prolactin. Then in case she does not have clinical hyperandrogenism, we need to see her free androgen index. Important thing about doing the testosterone and the SHBG levels is that we have to do it before 10 a.m. and in the follicular phase of the cycle. Third is we have to do GTT with 75 gram glucose, especially in Asian females or Indian females, because we are more at risk of insulin resistance or glucose intolerance. And last not the least is in case the female is obese, we need to do the lipid profile. And as we very well know that for the Asian population, the WHO describes obesity in Indian females if the BMI is more than equal to 23. Now, AMH is something which is very common nowadays. We do it for a lot of patients. But the important thing about AMH is that the test is still not standardized. So we should not diagnose a female with PCOS on the basis of AMH, as it is not validated. So right now AMH is only to see in case before ovarian drilling if it is safe for us to move ahead, and secondly it can be done in patients who are going for IVF just to see if they're at higher risk of ovarian hyperstimulation. Now coming over to management. So for management, the very important thing for us is that we have to measure the body weight of the female, BMI, and the waist circumference for each visit or 6 to 12 monthly with whatever the patient is more comfortable. The blood pressure needs to be seen annually. We have to do the glycemic status with 75 gram GTT at baseline and then repeated 1 to 3 yearly depending on what the test is like. Then lipid profile for overweight or obese women when the BMI is more than equal to 23. We have to optimize the various healths of the women in terms of mental status, emotional status, and the sexual status. And smoking and alcohol, if they are doing, it has to be cessed. Then next, coming over to the diet modification, as it is already discussed that it should be an energy deficit of 30% with reduced glycemic index diet. And in case the female needs a weight loss, then it should be a moderate intensity exercise of 30 minutes per week. Coming over to the bariatric surgery. So bariatric surgery, it is important or it should be considered in females who have a BMI of 40 kg per meter square and above, or in case the BMI is 35 kg per meter square in the presence of metabolic syndrome. So here it can be considered. The first line pharmacological agent which we are using now is letrozole for the ovulation induction, because it is less associated with multiple pregnancy as it is known to cause monofollicular development. And secondly, the risk which we had or the concern which we had in the past of it causing a congenital anomaly is no more proven, because there's a large data which says that the congenital anomaly rate with letrozole is much lower. Now coming over to the ovulation induction cycle. So for ovulation induction, our motive in PCOS is always a monofollicular development. We should trigger the patient at a follicle size of more than 20 mm with a flow around the follicle of 80%. We have to learn from the previous cycles. That is, if she has had a history of luteinized unruptured follicle, in those cases, never ever give a patient external estrogen. Trigger the patient later than than the day we did in the past. We should give a dual trigger to these patients, which is a HCG trigger plus a triptorelin trigger. Plus minus GCSF can be given to the female, ruling out the kidney problem in the female. Before giving GCSF, we should rule out any kidney problem in the female or any chances of leukemia. Now, history in endometrium, if present, in those cases, we have to start the vasodilators early. Clomiphene citrate should not be given in these females because it is associated with thin endometrium. We should try for development of 2-3 follicles by giving her gonadotropins along with letrozole and wait till for trigger till the endometrium is 7 to 8 mm. Now, next is if the history of OHSS is present. In that case, gonadotropin should not be given to these females. Preferably, letrozole should be used, and we should cancel the cycle if there are more than 3 follicles more than 17 mm. So these 3 important things are, first of all, if there is history of luteinized unruptured follicle, external estrogen should be avoided, trigger should be later, NSAID should not be given, and dual trigger should be given. If there is history of thin endometrium, then in that case, we have to start vasodilator. Clomiphene citrate is not to be given. Try for development of multiple follicles, which is 2-3 follicles, not more than that, and wait till the endometrium is 8 mm. And in case there is history of OHSS, then no gonadotropins, letrozole should be given, and we should cancel the cycle in case the follicles are more than 3. Now, next coming over, in case with the ovlogen or with the medications which we use, she did not have any response, that is the dominant follicle did not come up, then the next cycle, what different can we do? One is we should tell her for a lifestyle modification before going for the next cycle. So in that case, patient should have a weight loss and then should go for the next cycle. We have to rule out hyperprolactinemia, hypothyroidism, and hyperandrogenism in these females. And if present, it should be treated first, followed by the treatment. So for hyperprolactinemia and hypothyroidism, we can give them medication. And for hyperandrogenism, during the cycle, we can give her steroids. And we should add metformin in these patients in case there was no response in the past. Now, in these females, in case with oral ovulations, in spite of using all those things, the dominant follicle did not come up. In these females, we can use gonadotropins, which should be a low dose gonadotropin protocol. That is, we should give her very low dose of gonadotropins, and then like for 1 week at least we should wait and then go for the increase in the gonadotropin, which should be less than 50%. So it is usually 37.5 units of gonadotropin which is used initially. With time, we keep checking her if the dominant follicle is coming up. In case it does not come up, then after a week we increase it by 50%. That is how we go up in case of PCOS, because we do not want multifollicular development in these females. And in case the patient cannot come to the OPD very often, and she has a low BMI, she has a low duration of infertility, less duration of infertility, and she's young. In these patients, we can go for laparoscopic ovarian drilling. So that is also a procedure which can be used for females who are not forming a dominant follicle. So the things which we use is, one, gonadotropins. The other thing which can be used is laparoscopic ovarian surgery. So as we discussed, that laparoscopic ovarian drilling is usually preferred in females who have high LH, who need laparoscopy for other things. In case she has a low BMI and she has a low duration of infertility and she is young. In case female is of advanced age, has longer duration of infertility, she is obese, she has marked hyperandrogenism. In these cases, usually laparoscopic ovarian drilling does not work. So it is preferable that we use gonadotropins in these females. So that is a very important point, that which patient should we go for laparoscopic ovarian surgery and which cases can we prefer a gonadotropin. So with ovarian drilling, it has a very good ovulation rate and pregnancy rate, and usually it does not have any effect on the miscarriage. And the rule of 4 is very important in this case, that we should use 40 watt for the ovarian drilling, 4 punches in either ovary, 4 mm depth, and 4 seconds each. One thing which is of importance in case of laparoscopic ovarian surgery is that in case you drill the ovaries too much, or in case the patient goes for a second laparoscopic ovarian surgery, or in case she does not have PCOS, and we do laparoscopic ovarian drilling, that can lead to low ovarian reserve in the female. So that is a concern in these females. So never on the basis of laparoscopy, that on laparoscopy if we find the ovaries bulky, we should not do a laparoscopic ovarian drilling. That is a wrong concept which was there in the past, and we should not do it now. It is only on the basis of scan if we have a PCO morphology that we go for a laparoscopic ovarian surgery. The poor prognostic factors are low AMH if the BMI is more than 35, in case the LH level is low, or if the patient is fat, has hyperandrogenism. This is the low dose protocol. So we use the chronic low dose protocol where we are using 37.5 units of gonadotropin, and we increase it usually after 7 days by 50%. Which gonadotropin? Any gonadotropin can be used, either a recombinant form or a urinary gonadotropin. They do not have a difference in terms of the outcome. Now for OHSS, we need to know what is the risk factor. So in case the female is young, she is thin, she has PCO morphology, and there is history of OHSS. These are important risk factors for OHSS. In these cases, if you are going for ovulation induction, preferably don't use gonadotropin, go for letrozole ovulation induction, and also keep watching for OHSS. We should also screen for depression and mood disorders in these infertile population, especially because they are infertile, they might be having hirsutism, acne, obesity, which can challenge their feminine identity. Obstructive sleep apnea, it is quite prevalent in females who are obese and they have PCOS, which is an independent risk factor for CVD. So these females who have PCOS and are obese, in case they have snoring, in case they wake up unrefreshed from sleep, or they have daytime sleepiness, in those we can suspect obstructive sleep apnea and go for the investigations. So the summary is that it is a heterogeneous disorder. There are different phenotypes of PCOS, which can have long-term consequences on the female in terms of infertility or fertility, and also in terms of cardiovascular and metabolic risk. So lifestyle modification in case of PCOS is foremost, and always in case of ovulation induction, go for a monofollicular development. Always see the previous cycles, what has happened in the past, what changes can we make for a better outcome in future. Thank you very much.
Thank you, ma'am. Thank you very much. I mean, you have covered everything, right from diagnosis to phenotypes to management and the protocols as well. So thank you very much. Coming to the last presentation.
Thank you.
We have a last talk by Dr. Murtaza Kamal. Sir is MD Pediatrics and DNB Pediatric, also received special training in Pediatric Cardiology in Hyderabad. Sir is Director Pediatric Sciences, RNR Hospital and Kamal Hospital in Chunchunu, Rajasthan. More than 45 publications in peer-reviewed journals. Editorial board member and review committee member of various scientific journals, eminent teacher of pediatric cardiology in Indian Academy of Pediatrics, and special interest in fetal cardiology, adolescents.
Prachi, I think the screen is not shared.
Ma'am, something went wrong and I'm unable to share my screen. I'm so sorry about it.
Okay.
Let me share the screen. I'll just share it.
Yeah, okay.
Your screen is not shared.
Yes. Now, can you see the screen? Is the screen visible?
Yeah, it's visible.
Yes.
Yes. So our last talk is by Dr. Murtaza Kamal. Sir is MD Pediatrics from New Delhi, also DNB Pediatrics.
I
And
think you have already introduced me. That's okay. Now I'll share my screen. Hi, good evening.
okay.
Thank you.
Thank you, sir.
Can you see my screen?
Sir, not yet.
Can it be seen now? Is my screen
Yes,
visible?
yes, 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 sir.
Yeah. So good evening all. And first of all, I'd like to thank Dr. Prachi for the nice introduction. And special thanks to Dr. Prachi along with Dr. Payal and Shield Connect for giving me the opportunity to discuss some of the important findings which we do not discuss normally about kids. Like we are not at all concerned about the offspring, and we have been talking about the women with PCOS. So does it affect at all to the offspring? We'll see in our talk. And my disclaimer will be in this, that since I am mostly concerned about the kids, so my presentation will also be like a kid like. It will be just of 8 to 9 slides, keeping the time as for most importance. So we all are aware that it is a metabolic disorder with reproductive consequences, and approximately 25 to 30% of all the women in the reproductive age group have PCOS diagnosed in them. So basically, it's an interplay of ovulatory dysfunction on the background of metabolic findings, which predisposes the women to increased obstetric risk. Hence, since the women this predisposes the women to increased obstetric risk, so these children, so it will increase the risk to the born children. And we all are aware that late pregnancy events have immediate effects on the child's neonatal health. So is it really possible to improve these intergenerational effects with interventions? We'll be seeing these. So what basically is the influence on pregnancy outcomes of PCOS? The risk of miscarriage is increased up to 3 times. The risk of preeclampsia is increased. The risk of preterm delivery in these women is increased, along with gestational diabetes. And children and female who have PCOS, they are more likely, since they have more of the obstetric risks, they have more likely to undergo a cesarean delivery. So is there any role of infertility treatment which we give to the women? Because we know that women with PCOS are more likely to have had an infertility treatment. It is seen that they have multiple gestations also, because in those conditions in which we give infertility treatment, we go for multiple pregnancies. And the child born with IVF, they have a higher rate of congenital malformations and adverse health risks in childhood. There are 2 studies which are quoting about this. But there are not sufficient studies to suggest any direct association of PCOS with congenital malformations. Moving on to the direct effects on the offsprings, the chance of preterm delivery in children who are born to PCOS women is much higher. It's approximately double those of the normal general population. These children are more likely to undergo a birth asphyxia, having a low birth Apgar scores. They are more likely up to 3 times to have neonatal hypoglycemia. And since they will have these complications, they are more likely to be admitted in NICU and perinatal mortality. And even postnatal hospitalizations have been found to be higher in these group of children who are born to PCOS women. Even congenital anomalies have been found to be up to the extent of 7% versus the general population of 5%. and most common in them being the genitourinary and the cardiovascular anomalies. And the increased risk of hospitalization for children in adolescence, which mainly are musculoskeletal disorders, children with, they will suffer from respiratory illnesses, they have neurological issues. So these are the basic chances of getting them admitted in the adolescence period also. So not only in the early neonatal period, they are also affected in their long-term adolescence age group also. So the influence is long-lasting. This can be either genetic or other influences are also possible. Some Australian studies, because most of the studies on the offspring on PCOS women have been done from Australia, and basically there are 6 large studies which have been done, including around 20,000 patients. They have found that there is no correlation between the low birth weight, SGA, macrosomia, RDS and stillbirths in these children. Since these are preterm, they can have respiratory distress syndrome, but that is the chances of any preterm getting RDS. So PCOS does not itself predisposes to RDS. So the possible etiologies which they have given for this is the deranged metabolic environment in the mother with PCOS, because there are endovascular changes which are there, and there are increased oxidative markers in the circulatory system, even abnormalities of the homocysteine metabolism, which is due to the hyperandrogenemia, have been found, and there is impaired trophoblastic decidual trophoblastic invasion in the PCOS women, which predisposes the growth restriction, the chances of preeclampsia in the mother, and of premature delivery in these children. So the main point is, does any pre-pregnancy or obstetric intervention will improve the neonatal outcome? Yes, as I've been talking about in the last 4 lectures, we have seen the most important thing is lifestyle modification with diet and weight loss is most important. And metformin is the thing which has been regularly used in these children. And it has been seen that it's an insulin sensitizer which reduces the gluconeogenesis along with lipid synthesis. It inhibits it and reduces the gut absorption of glucose also. And it has been used for years to induce ovulation. Now and then you will find anywhere people are using this for ovulation induction in all parts of our country, although it's not the first line treatment. And they had a study in which in vitro study was done on mouse and fetal testicular cells, which were exposed to metformin, and they found that the Sertoli cell number and the testosterone secretion was decreased in the male offspring which they had. So will it have any adverse male reproductive transgestational effect? This has to be studied in vivo. We haven't studied it in vivo, but in vitro studies are there to suggest this. So basically, how can we reduce these chances which are there for the offspring of these women to get affected is by improving the periconceptional health in PCOS women. It may improve the reproductive outcomes. And there is evidence of improved reproductive outcomes for normal weight women in comparison to those PCOS women who are overweight. There is evidence for use of metformin for women with PCOS on reduced rates of miscarriage, gestational diabetes, preeclampsia and pregnancy. And the most important thing is preconceptional identification of women with PCOS. And this may enable us to early intervene and have long-term to reduce the long-term outcomes in these children. Thank you.
Thank you, sir. Thank you very much. It was really short and sweet presentation. So thank you. I don't see any questions in the comment section. So we will wait for any additional questions. Meanwhile, Dr. Payal ma'am, would you like to say a few words about this webinar? Ma'am, please unmute yourself.
I would like to thank Shield Connect and Prachi for giving us a platform to do webinar on PCOS. There's a need of the hour, and with rising cases every day in OPD, it is good to cause awareness and do more programs on PCOS. Thank you so much.
Yes, ma'am. Thank you very much. So it is an attempt to do a multidisciplinary kind of a talk session. So where the cardiologist is there, pediatrician is there, also the internal medicine doctor is there, and of course the fertility specialist is there. And you of course covered all the lifestyle modifications. So I hope we have covered almost all the aspects of PCOS. So this was an attempt by you and by the Shield Connect. So it's a collaborative attempt. So I hope audiences have enjoyed. There are few questions in the chat box. I will just read out. One is which vasodilator to be used? Maybe Dr. Badri
I think
sir
Dr.
or
Badri sir should answer that.
Dr. Prachi, can you please repeat the question?
the vasodilator to be used. That's it.
Okay, so this vasodilators I was talking about, in case a patient has thin endometrium, in those cases we can use vasodilators in terms of sildenafil, which can be given vaginally. Then we have L-arginine, which can be given to the patient. That is also a vasodilator. Then so these are the basic vasodilators which can be used in these females, and there are a few other ones which can be used but is not proven.
Thank you, ma'am. The next question is about the new molecule that is Reviterol doing in the treatment of PCOS. I mean, I have no idea, so I don't know whom to give this question.
Virtual. I think Dr. Meera can answer that. Again.
I think they are talking about resveratrol, which is a grape seed extract. And it is not proven, but yes, being a grape seed extract, it is seen that it can have anti-inflammatory cardioprotective properties. Not a proven thing, but yes, can be tried.
Yes, ma'am, if I can intervene in between, yeah, resveratrol is probably what the person means. And we have been using it as an antioxidant because it's been very helpful for the antioxidant properties. And whenever we wanted, we've had cases, probably Dr. Badrinaryanan sir can add the thing, where people have had issues with statins causing, bad myalgia, severe myalgia. In that case, we had to give any other strong inflammatory as well as antioxidants. And that time, that's Resvita or resveratrol, we have used it. And it's an anti-inflammatory which works for most of the time. Using in PCOS, not something which I have tried it out, but primarily the fact is that it's been used as antioxidant. Yeah. Thank you.
Thank you, sir. Thank you, ma'am. These were the only questions in the chat box, so no more questions. So I would like to thank each and every speaker, Dr. Meera ma'am, Dr. Ashish sir, Dr. Murtuza sir, Dr. Badri sir, and of course Dr. Payal ma'am. Thank you very much for your talk and giving us time almost for 2 years, 2 hours. We are over here. So thank you very much. Thank you from the Shield.
Thank you, Dr. Prachi. Thank you very much.
Thank you very much.
Thank you, doctors. Thank you very much. And then there are a lot of comments regarding the presentations, and everybody has enjoyed the session. The previous question, regarding the new molecule, this query was posted by Dr. Mamta Devi, and since the query came second, so she posted another query that my question is still unanswered. Now I am sure Dr. Mamta's query is answered by the faculty. Thank you very much, doctors, for your precious time, and thank you, audience, for being so accommodative. Thank you, and we will connect again. Thank you very much.
Thank you very much.
Thank you. Ever the last, hello?
Yeah, doctor.
Ever the last molecule still now is not very much used in general practice or cardiology practice.
Right, sir.
And not many drugs is not proven the efficacy.
Right, sir.
Just blind treatment.
Right, sir.
Anyway, thank you.
Yes, sir.
All and others, nice seminar. I enjoyed it.
Thank you.
Especially
Thank you.
Ashish Chavan on his marriage anniversary day.
So wishing many more great moments. Yeah, yeah.
Yeah. Okay. Well,
Thank you, sir. Thank you all.
Thank you.
thank you.
Thank you. Bye-bye.